honestly should be common sense to you, because all of you at this point have rotated through mobiles multiple times. At least I assume you have, most of you have. So really not much is going to be different in regards to what we're learning in positioning. We're just going to more so be learning a lot of terminology, rules, safety things that we do when it comes to doing mobile radiography and of course trauma room type patients. So what do we define trauma as? TVs are on. Reagan, can you turn the TV on next to you if you don't mind? These TVs are so messed up. So trauma is going to be what we categorize as a severe injury or damage to the body caused by an accident or violence. Those two reasons. That's going to be a traumatic type injury, not just a regular injury, but traumatic. And these are the ones that will require what we call immediate care and specialized care. That's going to be the ones coming into your shock rooms, your trauma rooms, the ones that call you in. You got to get those images really quick and get out. So they can occur by several types of forces. We're going to be including the blunt trauma, penetrating trauma, explosive trauma, and heat trauma. We're going to further define each of those and give examples of each of those categories that you see right there. So these will be what we call our multi-answer questions that you may or may not see on my test, as well as your registry. So here we go. Blunt trauma, what does that count as? Motor vehicle traffic accidents, MVTAs, your motorcycle accidents, collisions with pedestrians, like two people running into each other, would be blunt trauma. Falls and aggravated assaults all fall under what we call blunt trauma. Not to be confused with your penetrating trauma. That's going to be your gunshot wounds, your stab wounds, your impalements, foreign body ingestion, which is one we often forget about, and aspiration, all considered penetrating trauma. The last two especially, I would put a star by, because we usually don't really think of those as being penetrating, swallowing a foreign body or aspirating fluids or solids or whatever, but they do fall under the penetrating trauma category. I did send this PowerPoint, yes. Explosive trauma, several mechanisms. We have pressure shock waves, high velocity projectiles, and burns. Although burns kind of overlap in the next one as well. But this is about burns as a result of an explosion, essentially. Pressure shock wave. So you know how when there's an explosion, the shock wave bursts out and can kill or injure you? You ever seen a nuclear bomb make the shock wave first? Bombs also, regular bombs also make shock waves, and they can hurt you. Also, they can blow out your eardrums, do all kinds of stuff to you. Heat trauma, this is going to be our specific burn injuries such as fire, steam, hot water, chemicals, electricity, and frostbite. Once again, those last two are ones I would put a note by just because we don't often think of those as burns, but electric burns and frostbite burns are two real things as well. Frost burns being very painful.
You said that on the heat trauma. Okay.
They're all going to be considered heat trauma, even though not all of them have to do with heat directly.
During that freeze, was it last year or the year before? My sister touched the water and then she touched like some metal. Her finger was stuck, and when she took it off, it was like it looked blistery. She was fine, but
It's like whenever you put your tongue on like tongue on the pole and it gets stuck.
I never done that.
Yeah, I wouldn't recommend that.
Oh, you did that?
No, I didn't do that.
Oh.
Of course not.
Oh.
You sure about that?
I am very sure about that.
Putting your tongue on the pole and getting
Okay,
stuck.
so trauma radiography, I would say, aside from some of the visuals, trauma radiography can be very exciting. At least for me, I think it's exciting because that's going to be your challenging, think outside the box type exams where you're not going to be able to do just a regular chest x-ray, a regular hand, a regular neck, what have you. You've got to get creative in how you get that acquired exam. It can be intimidating and stressful. Prep is key. Make sure you know the general rules of how you do all your basic positioning, but be prepared to go outside the norm when you get to that trauma room, because if you've been in shock rooms already, which I'm assuming all of you have at this point, it's kind of a chaotic environment, yes? Or are they pretty calm here? No, they're never calm. I'm saying that sarcastically. No one's ever calm in the shock room. You always got the wrong people in there that can't handle the pressure and they're going nuts and screaming and hollering, and you're just sitting there with your machine waiting on your turn and they're freaking out. Where's x-ray? Hi, I'm right here. That would always be my response. I would be sitting there, just sitting there with my pro machine. I have my hands on top. Just be watching the show. Where's x-ray? I'm right here. I would say just like, I'm right here. I'd say, okay, I would say y'all need to get out of my way, except for you come hold the cassette and do my thing. get out the way. That's what you gotta do. You gotta work fast. You can't be second guessing yourself and trying to figure out what to do when you're in the middle of it. What I suggest you do from personal experience, because most of the time when you get in there, with a few exceptions, they're not really gonna immediately have you come in. Assess your situation first and be figuring out how you're gonna accomplish the films you gotta take. So you can get in there, get it done, get out the way. It's all about speed, it's all about accuracy. Your most common traumatic injuries are gonna be your falls, motor vehicle, and firearms, according to the most current statistics. Falls, motor vehicles, firearms, transport cut piercing, so on and so forth. Definitely those first two in Houston. Your elderly with falls, MVTAs, because we live in Houston with all this traffic, constantly having wrecks and lots of injuries. So mobile radiography, I'm gonna be going through this a little fast. I'll be focusing on the red parts, by the way. All these red parts I have highlighted for you are the main points I want you to know in this PowerPoint. Just a fun fact here, how many of you knew that mobile x-rays were first used in the military? A couple of you knew? They were first used in the military, carried to field sites for field operatives. So most of our technology that we use typically originates in the military. Even things like your cell phones in your pockets that originated in the military first. All the advanced technology we have typically goes to the military first before it becomes more mainstream for other people to purchase. So mobile x-rays are no different in that regard. Why? Because they're the ones developing all the technology. Yep. So as far as x-ray machines, mobile, obviously not as sophisticated. Are we all used to using mobiles by now? We're mobile experts. They got two new care streams at LBJ. They were in the room today.
You want an Aventa.
Yeah, they're real fancy. Mary showed me how to use them.
Yeah, I was kind of moving it out of the way for lab this morning, and man, that care stream had some juice on it. I hit that handle, it went
fast.
It about took off with me. Like,
Detector is really light. It's lighter, really. That's what I like to say.
they're very nice. Very, very
careful with
nice.
your
I was
foot.
using it with Mr. George yesterday.
Whenever you say juice, it reminds me of Gio, because when,
Juice?
Gio, because when he sees a patient, he'll be like, oh, we're gonna need some juice.
We're gonna need
Need
some juice. I can see him saying that.
Somebody told him, he asked, do you have something right here, sir? And the guy was like, no, only my maracas. And Gio was like, he was so sassy.
I love Gio. Gio is so funny. Gio would make me laugh every day in class. He'd just say the most
Whenever he
random.
looks like.
He'd do that confused look, or he'd just say the most random stuff.
And he goes, yeah.
He'll go like this, look. His facial expression.
Anyway, when it comes to mobile, guys, one thing to keep in mind is we're not going to be using AEC on mobiles. Have you ever used AEC on mobiles?
No.
Does it even exist on mobiles?
No.
No, it does not. So it's all about those manual techniques, mastering them, knowing how to set those manuals for extremities, chest, abdomen, head, neck, whatever. So your typical mass range on a portable will be at a minimum of 0.04, very important numbers to know, by the way. Minimum of 0.04, maximum of 320. Unless you have a very obese patient, please don't use 320, you're gonna blow up the tube. And make it very hot. KP, lowest is gonna be 40, highest usually 130. Yeah, Gio, don't crank it up to 320. Your power is gonna vary between 15 and 25 kilowatts. And some have what we call APRs, present anatomic programs. Y'all know what those are? Basically, whenever you have the screen, you select chest, it automatically sets stuff for you.
Oh, yeah.
That's your APRs. Although not 100% reliable, because some people set these machines up incorrectly. Make sure you look at what it's setting your techniques to. I've seen machines where you select chest, and it would be like down at 40 at 2 mass. And obviously that's not gonna shoot a chest, that's better gonna shoot a hand or a finger x-ray. So make sure your APRs are accurate before you 100% rely on them for your x-ray techniques. Let's see, digital capability is what we're all using now. Gone are the days of the clunkers. Thank God, I hated the clunkers. Have y'all got to use any clunkers at all?
What's a clunker?
CRs on mobiles.
No, thank you, Jesus.
Y'all are so blessed.
That was
I say again, y'all are so
They
blessed.
were big, right? They
And
were
we-
very big.
They really weren't that much different in size,
Okay.
but the digital machines are very smooth, like they kind of glide.
Uh-huh.
The clunkers are very clunky. It's like old Betty in there. That's a clunker. I mean, she makes noise, clunkada 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 clunk when you're going down the hallway. You had to carry all your CRs in that little tray. You had to take your X-rays, run them in the machine, pray that you got it right. Dr. Blake was film. That was even worse. We used to think CR was fancy. Yeah, CR now seems so old school.
He did CR said, I'm so blessed.
But y'all are so blessed with DR because now when you do a mobile X-ray, you immediately see if you need to repeat that X-ray or not. You don't have to go run the film. Which when I used to do morning portables every morning, that was a nightmare because I'd do like 30 morning portables every morning, and I'd have a whole stack of these cassettes, be running them, and there'd just be that one or two that I might have clipped a concentrating angle. It would just ruin my whole morning. I had to go all the way back, repeat that X-ray.
So like
Run it
these
again.
patients, they're waiting while these are being ran, or like they go home and if you mess up,
These
you
are
got called
inpatients.
back?
Like morning
Oh.
portables are always on inpatients. And at TCH typically you have like 20 to 30 every morning.
Would you do a few of them and then go run them, or do you?
I would usually try to do them all at once because I didn't like to go back and
Well, how many
forth.
cassettes did you have?
I had about 30 cassettes.
Oh
I would so I would put about 15 in the tray. The other 15 I would set in this little corner of the hallway, and I would switch them out. And then when I had them all done, I would take them all back to my
You
little
weren't scared to
office
lose one?
and run them in there, huh?
You weren't scared like to lose a cassette?
No, I was very efficient.
How'd you like?
OCD here. I was very efficient. Hmm?
Yeah, how'd you know what number? Yeah. Was when?
I memorized them all.
Nah.
Oh,
Nah.
here we go.
So what I did
Yeah,
was
that's
I printed out every single order and I would take them each cassette. As I took them, I would just, well, actually, let me take that back. It wasn't the orders. Every patient's chart had little stickers. They used to use stickers a lot at TCH. They were like little thin strips that look like this. I would take each sticker and put it on my film and label each one accordingly. That's how I figure out what I was doing and run them correctly. But yeah, it's all about efficiency. When you got that many
You
portables,
said $18 an hour is not enough.
ugh, yeah. I mean, that seemed pretty good back then, though, for all this inflation hit.
It was
Yeah.
good back then.
Mm-hmm. So flat panel detectors are going to be the main type of detector for your portables. Make sure you know that. Very important. They wirelessly, they no longer use cords, wirelessly transfer images. By the way, the first digitals that I got to use, we had to plug them into a modem socket to send our images over. It wasn't wireless. That was a little inconvenient. And lower radiation doses possible due to the fact that we're using digital post-processing. So in other words, overall less dose, because even if you really screw up that technique on a portable, the algorithms are so powerful now it kind of self-corrects it for you, which is nice. There's still, I mean, you can still really mess it up, but you have to really go out of your way and just really not know what you're doing to mess these images up now. If you've really messed it up, I'm sorry. You really messed it up because the algorithms are self-correcting now and they're really giving you a lot more room for error. So like, you almost have to like try to mess your images up. The only way you'd really like mess an image up is like if I did like a chest at like a hand technique or something like that. No amount of algorithms is really gonna correct that. But if I was say like a little bit off my KP and mass, it's gonna optimize that image with the algorithm, fix it up for you, and you don't have to repeat that image, which is really nice.
Yesterday we had a really chunky
My
patient
voice is
and
going
we did a KUV. Well, when you looked at it, you can't really like tell, you know, the gas and stuff apart, but then when you did that window or whatever,
Windowing.
yeah, it looked good and then they just send it like that.
Mm-hmm.
They're
It's
like,
really,
they
it's
can-
really nice that you can do that
They
now.
can fix that, no.
Yeah, it really makes the job a lot lazier.
Yeah.
Which, hey, I wouldn't complain either. You know, embrace the technology. I'm not one of those things like, back in my day when I used to walk barefoot in the snow, you know, y'all don't know how good you have it. Like, honestly, I'm glad it's better for y'all. It's a lot more efficient. Technology is a great thing. Embrace the technology. Seriously. Seriously. I'm giving y'all a hard time in class, but really I'm happy for y'all. Yeah, so, technical considerations, 3 major things for portables. Grids. What are grids for, guys? Thank God y'all all said that finally, because seniors last year, my God, even on their last semester, they kept wanting to say it was for dose. Are grids used to reduce dose at all?
No.
They are not. They are purely and primarily only for scatter. We actually increase dose. Very good. Anode Hill effect, what is that?
Like the thinking thing, other side you put towards.
Put the thick side towards the what?
The thin anatomy side, thick side towards the thin anatomy.
Say it again.
Thick side of the filter towards the thin anatomy.
What side's on the anode side? That's what
On the, on a foot, sir? On what, sir? On a body?
the thinner side toward the anode, the thicker side towards the cathode, and that's gonna give you a more uniform density across your image. Not required, but it does give you that subtle optimization to your images. Thankfully, with digital technology, it kind of mitigates that for you a lot more, but still it's gonna give you a more enhanced image if you embrace that anode hill effect correctly. SID, because we always do 72-inch SID for our portable chest, correct? As everyone laughs as I say that.
No.
But
We can try.
Looks good enough.
don't ever say that. I hate that phrase. I cringe when people say that. It's never good enough. It can always be better.
How about close enough?
It's never good enough. It can always be better. SID, guys, does make a big difference. Whether techs tell you that or not, they're probably going to deny that, but it gives you that further optimization, something you want to utilize correctly. 40 between 72, depending on the type of exam. Really, the only two 72-inch SIDs you should ever use in radiography mobile exams would be your chests and what other parts?
The
Lateral C-spine,
Right.
which you will do a lot of those portable. Very
I've
good.
never done a C-spine before.
I ain't even seen this.
They don't do a lot of those at Harris Health. The cross-table Cs, we used to do them all the time at TCH though.
Miss Fulton.
But really, and this is my theory, those are becoming more and more rare because they just send them a CT automatically these days. And they just fry all the patients in CT. I have a lot to say about that I don't like, but that's a whole nother subject. I am. I still don't like how they use it.
On the note of it's becoming more obscure, why is it still considered a mandatory?
Because we
Like,
still-
Because the
cross-table
ART
spine.
says so.
We
And he
do it in
doesn't
the
work for
exam
Harris.
room.
He works for Harris.
I think this hair cell that's not that common, right?
He probably wants
I mean,
to have jails.
I've been out of
What's that?
X-ray for 5 years at this point, but I know they were quite common at TCH when I was working there. I don't know if it's a Harris Health thing that they just don't like to order them as a CT or what, but I honestly,
I'm gonna let
my
Brandon know.
opinion is they're going to be more and more rare because
LinkedIn.
CT has just basically started to take over everything when it comes to trauma. It's automatically send the CT. They don't need the C-spine anymore, so
Well, cause it's quicker and you can.
it's quicker, but at what cost? That's what
Better
I say.
cells.
Well, it gives the hospital some good income, I know that. But, yeah, MRIs and CTs, man, they pay a lot of money. Goodness. Okay, sensitivity to CR imaging plates. Let's see, levels. Let's see, optimum performance grid. Let me sure you didn't know this here or not.
I'm not sure, it's somebody.
Main thing here, guys, main thing I want you to know on this, guys, even with digital plates, even though, once again, they correct a lot of it, make sure you're centering to them correctly. In other words, don't put your hand over on the side of the plates. Put it directly in the middle. Make sure you're aligned up to that properly. That's another way to further optimize those images and just get that little edge. It's gonna look better than your coworkers. You got a lot of lazy techs, and hopefully you're not seeing this. A lot of lazy techs just slap the hand right here, slap the foot on the corner. Like, oh, it's fine, it's digital, it just gets it anyway. That actually degrades the image quite a bit compared to if you had it central on the cassette. It really does make a big difference. Let's see, go forward here. Anode hill effect there again, guys. Y'all know what that is. Causing that decreased image density under the anode side. More pronounced when you have a shorter SID, larger field size, small anode angles. Proper placement. It says essential. I wouldn't say it's essential per se, but it's really going to give you a better looking image overall. A lot of people try to say, oh, it's just such a subtle difference. It really gives you a lot higher spatial resolution on your image. It just makes it more beautiful. So when you can utilize anode hill effect, do it, but it's not like a requirement that you have to, because digital technology does fix quite a bit of it. And obviously in some cases, especially if they're like in the ICU or the trauma room, you gotta get in there, get your image quick and get out the way. You can't always guarantee you'll have anode hill effect. But when you can do it, it really does make a big difference. Technique charts. How many of your machines have technique charts on them?
A lot.
Maybe you
Should be all of them.
question. Do they all?
Probably.
Should be all of them.
They should. Not all of them have it, because even when I was looking at the portable machines today, they didn't have technique charts, but they should, to help you set those manual techniques that you do need to master. Just like with X-ray rooms, every portable machine is going to shoot differently. I don't know what's going on with these manufacturers, these X-ray machines, but even amongst their own equipment, you can have two care streams side by side, same model, same year, and they both shoot completely different. One might shoot hot, one might shoot cold. In other words, I might have to do like increase KVP on the machine on the left, decrease KVP on the machine on the right. I don't know what that's all about, but every machine does shoot differently. And of course, different brands shoot differently as well. Should have calipers. It says you should, but honestly, no one uses calipers anymore. We learn to eyeball that. We learn to eyeball the size of the patient as well. Set your technique accordingly with that manual technique. Have you ever used calipers?
What is that?
That's how
Well,
you
you know what it
measure
is,
the.
do you?
Yeah,
We used to, and now it's the phone.
We used to be
Need 'em
we used to be required to use these. When I was a student, every comp we did, every single competency and proficiency, mind you, that we did, I had to measure the parts, get my centimeters, take that centimeters, plug it into a formula with my KVP and mass, and calculate skin dose per projection. That was part of our competency, to calculate skin dose by hand, not with a calculator, by hand, formulaic equation to calculate skin dose. That was part of the whole competency.
The dark ages.
In the
Dark ages.
Yeah, it was a dark age.
So why
Pointless
did,
info.
why did they go away with that? Does it calculate itself?
Because it does it automatically for you
Okay.
now. You can just get it off the machine.
Yeah, okay.
Machines used to not do it for you though.
Mm.
Plus, my teachers were just sadistic like that.
Yeah.
I think even if it did do it on the machine, they would still make us do it. They're evil like that. I'm curious if they still are making their students,
That'd be
go
really,
ask them that
really,
new student if
really
they still have to do
dumb.
that.
If they
That'd
still make them
be
do
really
it.
sick if they still make them do
Yeah.
that.
That'd be kinda
Okay, maybe I should introduce that to the next group of juniors.
You should. You really should.
Oh, come on, y'all supposed to be nice and not want to wish worse on your people coming behind you. Come on now.
They're a big.
I said no, okay?
Okay, so radiation safety. So big star on that first statement, guys. This is a safety question from the registry in the italicized bold red print. Mobile rad produces some of the highest occupational radiation exposure for radiographers. You might know why that is.
Yeah, no shielding, you're right, very close, the side is very small.
Well, you're on the right track, but mainly because we don't stand
Distance
6
from
feet
the
away.
patient, yeah.
We don't wear lead shields. Those are just standing there
Hospital
holding the
beds are
patient,
closed.
not even putting the lead on. Just in general, it tends to be a lot of sloppy practice in mobile radiography where we're not. I can confess my own sins. I did many X-rays where I didn't even wear a shield. I just jumped in there, held the baby, took my X-ray, didn't have a shield on, did my thing, and got out. Because you're in a hurry, you're being rushed sometimes, and you just you don't think about it. But that's why that translates to higher occupational dose compared to other areas. Protection for self, patient, and other personnel. Wearing the apron, sent as far away as possible from the tube and beam. By the way, what's the minimum distance? It's in bold there for you. 6 feet or 2 meters. They might use both numbers, 6 feet or 2 meters. And we want to stand at least at a right angle, 90 degrees to the primary beam. By the way, if I'm standing 6 feet from the tube and it's pointed at me, is that helping at all?
No.
6 feet behind the tube. Behind the tube is what you typically want to do.
Wait, no question. I thought it was 6 feet from the patient.
6 feet from the tube. 6 feet from your X-ray tube is where you want to be. Yes. Distance, that will always be your most effective radiation protection measure. I would also write that down, put a big star on it. Safety section question on the registry. Distance will always be the most effective rad protection measure. Not that there's not more, but that's the most effective. Always inform all persons in the area that exposure is going to occur unless there's some nurses that made you mad.
That's right.
That's when you whisper it. Not really, you didn't hear that from me. Turn the camera off on that one.
Edit it out.
Do allow the personnel to leave and avoid the exposure. Provide lead aprons. Make sure you do, in real life, make sure you do vocalize to them. Either say, X-ray really loud. Would you like an apron really loud? Because often, especially in a chaotic environment, they selectively hear you. You might say, like Shameka here is like rushing around the patient. Would you like an apron? She just ignores me. And I'm like, well, screw her. And I go over here and take my X-ray. Then Shameka's like, why didn't you offer me a shield? I'm putting a safety scoop in on you. Well, even though I offered it to her, I didn't offer it at least twice. That's the key factor there. They offer it at least twice. That's the rule of thumb. That's the rule of thumb. You offer it at least twice loudly. Then, if they still either do not hear you or refuse, make sure you write their name down in your documentation, the time, when it occurred. That way, if Shamika is wanting to still be really mean, because John took an x-ray and exposed her ovaries, like they always used to say to me, they exposed my ovaries. I have documentation that I did offer her a shield twice, and she refused and or ignored my requests. That covers my tracks. And I've had that happen multiple times.
Really?
Yes. Also, I always make sure I shout X-ray twice, because I'll say X-ray, and Doolally over here is just still like in the way. I'm like X-ray again.
She's still over
There we go. Beep. All right. So Doolally, Nurse Joy over here, did not move away from the premises when I shot X-ray after informing her twice. Time 2:45 p.m. May 13th, 2000, whatever. Hmm? It's a lot, but it covers your tracks. Because nurses, man, they will throw you under the bus so quick, they will not mess around with it either. And if you haven't experienced already, they see X-ray coming, they flee the scene. So most of them just start running away. They either run away or they're in the way.
Mm-hmm.
One extreme to the next.
Ask her for help.
Mr. Johnny,
Yes.
we don't wear shields when we go with the mobile as a practice.
You only should wear a shield if you are holding the patient or the cassette.
I see.
Otherwise, you stand 6 feet
And we
behind the
don't
tube.
carry it either, so.
Your shield should be on the machine. You should have aprons on your machine at all times that go with you.
Will you
Yes.
just run away?
So I tell you right now, I used to work the NICU all the time, and more often than not, in the NICU, I gotta be right next to the baby, trying to hold it still, and I'm holding the baby with the button, doing multiple things. So I've got my lead on. It's a lot of hands-on in mobile radiography, especially with kids. You go in the field with the kids. Rad safety. Only thing I really need you to know there, guys. Obviously, shield. We're gonna shield everybody. We're gonna shield everybody, despite
Everybody.
Except the
despite
nurses.
what our techs are doing out there. Please have a shield on your machine. Shield everybody. You'd want your family members shielded too. Minimum source of skin distance for all mobile radiography exams should be 12 inches or 30 centimeters. Please write that down. Put a big star on that. It's another registry question right there.
That's on
Minimum
our test
source.
today.
Was that on your test today?
Yeah.
I was
Good.
looking for 12.
Good.
Right.
If there was 12 centimeter, I would have.
Minimum source of skin distance, 12 inches.
We put a shield on her big old belly.
Okay, so trauma classification, very important terminology here, guys. Trauma center, we know what that is, but there are 4 levels. Level 1, where's the only level 1s that we have currently, by the way, in Houston? Where else? Memorial Herman, Memorial Herman, yes. There's about to be a 3rd
Oh.
at LBJ.
LBJ. Oh, next door.
LBJ is gonna be upgraded to a trauma 1 once they do that expansion.
Mm-hmm.
So that's your most comprehensive, that's your 24-hour care, 24-hour trauma care. Level 2, it's gonna be specialized care, but is not a research or teaching hospital. Level 3, smaller communities, resuscitate, stabilize, assess, and prepare patients for transfer to a larger trauma center. So it's like the mid-person, basically, before they get to the real trauma room. Level
It's
3.
a level 3.
Level 3. Level 4, locate your clinics and other outpatient settings. That's going to be your minor injuries and offer stabilization until they can get them to a real trauma center.
What does TCH fall under?
2.
Aren't they all 24/7?
Hmm?
Are they all not?
All ECs are 24-hour, but not all trauma centers are 24-hour.
What about little urgent cares? You know, sometimes they'll be like open to pharmacy. What would those mean?
Urgent care would be probably 4.
4.
Yeah, 4. Yeah, that's, you know, if it's too extreme, that's gonna be the ones that get life flighted to like Memorial Herman or Bentov. You know, life flight them in really quick, get them to that trauma 1 area to get that care nice and fast. Huh?
Which memorial is level 1? Where's all of
TMC.
them?
Yeah, the main one,
Over here.
the medical. Yeah, they have life flight coming in every 5 minutes. That
Really?
hospital.
Yeah.
I was at the zoo with the kids a few weekends ago. I swear there was 10 life flights, just one after another, coming in while we were there. Like, man, must have been some bad wrecks in Houston that day. Goodness. Obviously, guys, time is a crucial element. They will be rushing you in the trauma room. Have y'all experienced that in the shock rooms? They rush you really quickly. You gotta work quickly. You gotta know what you're doing. You gotta get in there and get out. Some rooms have these nice tubes in them. Y'all probably seen some of those.
I like that.
But you don't always have that. And at least where I worked at TCH, it wasn't Trauma 1, but it was always mobile exams with my digital machine going into those trauma rooms. But it's nice when they do have these machines on hand for you. There's this new prototype trauma x-ray machine. I forget the name of it, but it's very fascinating. I'm surprised it hasn't caught on more. It's probably because it's too expensive. But it's a specialized trauma x-ray machine where a patient on a stretcher is just basically run under a tube. Like the tube would be above the patient, is run them under it. It does a full body scan with very low dose. And there's a full body image like in like seconds. You do an AP, and you put it on the side, it does a lateral, full body, lower dose than an x-ray. Very cool machine. It's not really caught on yet, I'm assuming because it's too expensive. There's like 5 of them in the US. I can't remember the name of it, but very cool stuff.
That's only if they have
They're not here, I know that. They're all over the US.
that would only be if they have like multiple fractures, right? If it's just a hand.
I
it's
mean,
not into the whole body.
It's such low dose, I think they just do the whole body, just like whoosh, put them in there and they got everything they need.
Ooh, that would be good for trauma, no?
Hmm?
That would be good for a trauma patient.
Mobile radiography, often used for your ED procedures. Specialized beds and stretchers with movable trays. Use your trays. Not all beds have trays, but most of your trauma rooms have trays underneath the stretchers. Try not to be shoving that cassette underneath your patients if they're in the trauma room. Not only is that going to make their injury worse, but it's going to get stuck, especially if there's like blood or feces or sweat or all kinds of nastiness everywhere. Use a tray. Keep your stuff safe. Keep it clean. Remember, those plates are $100,000 each. I do have confirmation on that as I have been working on the purchasing of this room next door. They really do cost $100,000 for just the plates, each plate, not counting the room. So take good care of it and use those trays underneath your beds. Obviously, CT, being a jerk, is taking over radiography in the trauma room, but it kind of makes our job easier. Basically, everything in trauma rooms these days, if it's a very extreme trauma, first thing they say, send them a CT, send them a CT, send them a CT. It does give you superior imaging, but of course the cons would be you're just really doing extreme dose to your patients. And honestly, the cons for me is, I feel like they've just kind of blurred the line between what's trauma versus what's minor. And they just got so used to saying CT for everything that you got one person with a brain injury, yeah, CT, definitely. But then you have someone with a paper cut on their finger, oh, just send them a CT. And it's just pointless. And not only are you exposing the patient, you're sending them a big fat bill in the mail as well, needlessly. And I always say that because, just talking about from an ethical perspective, try your best to do your images right on the first time with as few exposures as possible, because keep in mind, every x-ray you're taking on a patient, that's a bill they're getting in the mail for every exposure you take. It monitors that, it keeps record of it, it sends the patient a bill. So your sloppiness, if it's sloppy, is going to cost that person more money. And a lot of people don't have money to pay for
Something
medical
has
stuff.
taken a wrong image and then I repeat my image, then the patient gets charged for 2
They do.
images.
If you send both, right?
Even if you don't,
Wait, what?
even if you don't, it charges per exposure.
Oh, wow.
Why is that? That's so weird.
Because the
especially when you're
hospital, the medical business is very crooked.
doing it. It is, but
I'll
geez, that's
leave it
horrible.
at that.
That
I'll
is
leave it at that.
horrible.
You think the insurance companies are crooked? The hospitals are crooked too.
Oh.
I will leave it at that. They are very crooked.
That's funny.
By the way, this is that machine I was talking about. I forgot I had a picture of it in here. This is it's a very weird looking stretcher, but you put them on this specialized stretcher that's radiolucent. You run them under the tube, takes a full body scan, turn it, run them through again, full body scan in the lateral. So when those, I'm assuming those will catch on more as the technology becomes cheaper. Very cool device. It's gonna be the future of your trauma rooms right there.
Kind of told us when we could get our project on that.
Yeah, I forgot the name of it, but that would be a cool project. It's called NextScan. Something, I can't remember what it's called.
It kind of looks like the beds that they put the baby on.
Mm-hmm. Kind of does. So obviously, most of your patients in trauma room will be immobilized. This is going back to patient care. Should be common sense. Do we ever take any of the immobilization devices off? at any
No.
point.
Mm-mm.
What if it's covering up what you gotta see?
They don't
No,
pay me
the
enough.
doctor has to do it himself.
You talk to the doctor and you have them do it themselves.
Yeah.
Exactly right. Do we ever remove seat collars? Do
Mm-mm.
we ever remove restraints?
Mm-mm.
Do we take backboards out from behind the patients?
No.
Please don't do that. Leave the backboard most are radiolucent. You leave everything in place until you're instructed to do otherwise. And if instructed, make the doctor or the nurses do it. Typically, you don't want to be hands-on removing any of that stuff. Patient motion, always a consideration. Therefore, when it comes to all radiography, not just mobile, we're always going to shoot for, no pun intended, shoot for the lowest time possible, shortest exposure time possible. Not only for dose, but to mitigate motion artifacts. Let's see, primary challenge as a trauma radiographer is going to be those high quality diagnostic images on the first attempt. And let me tell you, at least, once again, thank God y'all have the digital that shows you the image right away. Because whenever I first started at TCH in the trauma room, it was still just the CR. And you'd be in there, things going nuts, doctors hollering, nurses going crazy. You'd get your x-rays, but they'd all be CR. So we had to go next door and run those films after we took them. And I would always, I so cringe thinking to myself doing this, because I've made mistakes. I've made a lot of mistakes as an x-ray tech. I might miss a part and have to repeat it, and I gotta slowly walk back in there with my machine, and they're looking at me like, give me the stink eye. What do you want? Like, what do you want? I gotta repeat one x-ray. And they're all mad and cursing out, and some are like, just forget about it. We don't need it. And
We'll send
awkward.
it to CT.
Awkward moment, but
Where they won't miss.
thankfully now
Aw.
with the digital, you know right away, and you can make your adjustments, take another x-ray, and get out.
I've only been like in one case where we took the x-rays and everything, we did it as best we could because of the patient and the sickness, and the doctor called and was like, I need this in a different unit. So we had to bring that into that, put up with more
Frustrating.
pain, yeah. He was pretty upset.
That's always so frustrating.
He's like, why didn't you do it the first time? It hurt really bad. It was like an ankle or something.
You tell them to quit their
They'd be
whining.
like,
Really
"Well,
bad.
pick that up with the doctor said.
So when you say, why did you order something more?
Hey, you know, half the time these residents don't even know what they're ordering.
I know they
really
don't. They have no idea what they're doing. No idea.
So frustrating.
You often know a lot more than the residents do,
Yeah.
honestly. So minimize risk of aggravated patient condition. Typically position the tube and the IR instead of the patient or the part. Should be common sense. Place the stretcher adjacent to your bucky or upright table. Utilize the tube in the most efficient manner, and don't be afraid to get creative. Because obviously, if a patient comes in with their foot elevated straight up in the air and they're prone, and the doctor wants a 3-view foot, that's gonna be very unorthodox, right? You know what I'm talking about? If the patient's prone and their foot's just straight up in the air, they're in traction, and they want a 3-view foot, how do you get a 3-view foot?
Angle?
In other words,
Best way you can.
in other words, they give you a crazy drawing because I've had this happen to me. I've drawn it for y'all before. Patient's on a stretcher.
This is the pencil guy, right?
This is not the pencil, guys. It's something else. This is the foot. They're just like this.
That's one foot?
Foot up in the air, one leg down here, just like that. They said, give me a 3-view foot. They can't be rolled on their back. What would you do?
He's laying on his stomach?
Yeah,
Lay
he's
on his
prone.
stomach.
Flex the
Put the-
foot,
put the
balance
stretcher all the way
plate.
up.
Wait,
You
so
would
Just
do
put
an
the thing on
upside
top.
down foot.
Yeah.
Upside down
You
foot.
put the IR right here,
Mm-hmm.
shoot this way, just like that. It'd be very weird, but it still works.
wouldn't it be from the other direction?
Held it.
You held it and then.
Oh, you'd have to put a.
I held it set, I have a trigger.
Mr. Donahue, wouldn't it have to be from the other direction if they're prone?
Hmm?
The tube?
Still try to
Because
Coming this way.
The foot, yeah, cause you're
the
going through
foot
the
is
foot.
is bent the opposite direction.
But the foot is still.
Because right now you have it in, like set up as if the foot was pointing towards their head.
Now draw the toes backwards.
Yeah.
Toes are on the other side, I'm sorry.
No, no, no.
Y'all trying to act me.
Well, he said he was
There
on
you
his
go.
stomach.
Is that
So
better?
the
Exactly.
foot- the
So
foot
look,
would be this
look,
way,
my
right?
toes
Oh,
are gonna be
he's saying-
pointing the opposite direction.
Oh,
Yeah.
yeah.
If he
So-
was on his back, then the toes would be
If
pointing
that's the
towards
only
his head.
direction you can still go, you get the best image you could in that direction. But if you could go from the other direction, Yes, but once again, you're gauging your situation, your maneuverability, the amount of space you have,
Mhm.
things like that. In my case, that's how I had to do it. And it turned out pretty decent. It was very weird, but it turned out decent. Obviously, we do the AP, the upside down AP, and then how do we get the lateral?
Turn it
Upside down,
sideways.
cross
Turn it
table lateral.
sideways.
Upside down, cross table
Oh,
lateral.
no.
So that's why I said, you know, in retrospect, even though the trauma room is kind of crazy, it can be fun if you like to be creative. And I always like being creative in X-ray and making my own positions and stuff and doing stuff differently, so. Okay, factor compensation may be required, especially if they're immobilized on a backboard. If there's pathologic changes, what would be pathologic changes?
With the blood tests and all that, urine and.
What's a pathologic change? We've talked about this. This is a registry concept. Very good to review right now. You said pneumonia. That's one thing. Let's say the patient has severe pneumonia. They need a chest X-ray. What kind of changes based on pathology do I have to do with my techniques?
Oh, because he's got water
We
in his
increase the
thing.
technique. Why?
Because he's got water in his thing, so there's more.
Because there is fluid and pus in the lungs due to pneumonia.
And there's more
What if they have a pneumothorax?
Then it's air in the
Decrease the
thorax,
kV.
so-
Decrease pneumothorax because there's nothing but air. There's less tissue, there's more air. What if they come in with ascites?
Also
Increase.
liquid, so then.
Increase.
What about empyema? You increase.
Pus,
What
so all
about
the.
empyema?
You got pus, so all the more thick.
What is
so-
empyema?
Got pus
What is
and-
empyema?
It's got pus.
Pus, correct. So we increase. What if they are hemorrhaging
Also
inside?
increase.
What if they're
blood.
internally hemorrhaging?
Blood increase.
Increase. What if they have, what if the order says they have osteoporosis?
Oh, that's become less.
Decrease. What if they have emphysema?
Emphysema is what?
Decrease. So just a few examples. We're gonna be doing a lot of those next
What
semester.
about the ones that don't have like?
What is emphysema?
Yeah, no, the air did not like leave. I forgot what they're called, but the little,
Bronchioles?
no,
Nodules?
yeah, they're like, no, not inflamed, like you said they were like carved in, that they had like. And you said that you decrease the mass because it doesn't have any tissue around it or anything.
I said that?
Yeah, I forgot what it is.
I forgot too.
Yeah.
So anyway, just keep in mind the pathological changes you might need to make with your techniques. That's another really important registry concept they've been asking a lot lately. Situational questions. Patient presents to the trauma room. They are known to have emphysema. What would you do with your technique? You would decrease the technique because emphysema is a destructive disease. There's less tissue. If it's an additive disease, we increase the techniques. One of the most important ethical responsibilities is rad protection of the patient. Yes, members of the trauma team, and of course yourself. Make sure, once again, you are informing everyone twice and loud of protection purposes of either get out the way or put a vest on before you take that exposure. If they are refusing as such, you're going to document accordingly. Hello. What we doing over here? What you facing the opposite direction for? At least pretend to be listening. Come on, that's not even subtle.
I am listening to you.
That's not even subtle. Come
I'm
on.
multitasking,
Okay, keep telling yourself that. All right, so rad protection practices. Close collimation, obviously, should be common sense. Gonadal shielding for, I won't say beyond childbearing age, all patients. Go ahead and shield your elderly patients, guys. Just because they aren't having kids doesn't mean they may not develop cancers later in life. Do the right thing, shield your patients. Aprons for all personnel in the room. Exposure factors to minimize your dose and scatter. And yes, the very loud announcements of, I love how it says impending exposure. It sounds like impending doom or something. Impending exposure to allow unnecessary personnel to get out of the room or get out of your way. And you have to get used to being loud, guys, because if you have a really soft voice, I used to not like to shout loud. I used to be a lot more quiet than I am these days. You gotta learn to be very vocal because they're not listening to you. In X-ray, they always say we're invisible. We really are quite invisible. They don't know who you are. They don't see you. If you're not announcing your presence, and you take that X-ray and you weren't loud enough, they're gonna freak out on you.
Yeah, like Tia?
She loud?
No, are you kidding me?
No, she's not loud. I didn't think so.
No, but when she talks normal like this, we're like, whoa, stop screaming at us. Like one time she had to do the huddle, and they were like, whoa, Tia, relax.
Okay, so patient history, obviously going to be a little less intensive than you normally would do for patient history because you might get in there and it might just be a John Doe patient. How would you get your patient history? You got to communicate with the staff and the doctors to find out what's going on. Hey, what's the condition? What's happening? What do you need? Blah, blah, blah. If the patient is conscious, you should still explain what you're doing in detail. Yes, even if they've got a limb chopped off and they're screaming bloody murder. Amongst the screams, explain what you're doing as well in a calm, reassuring voice to give them as much comfort as possible. Listen to their rate and manner of speech. Provide insight to the patient's mental and emotional status, especially because, once again, some cases you're in there with the machine, everyone disappears, and you're in the trial room by yourself. It should not happen. It does happen sometimes. If that patient starts coding on your watch, you gotta be able to recognize that and get everyone back in there quickly. Eye contact, once again, comfort and reassurance to your patient because they're going to be very, very scared, very traumatized by what's going on in that trauma room. What was so funny that I said there, Jay?
It was just, I imagine walking into a room, patient missing their arm or whatever, like, all right, I'm just gonna slide this board under your arm. I'm gonna
It sounds
rotate
funny, but
your
but
arm.
You should be doing that. You should be doing that. I mean,
I hope you didn't feel that. Did that hurt? Oh wait, never mind.
I'm here to do your hand
You have
X-ray. Oh
nothing
wait,
to
man,
feel.
there is no hand. Okay, I'm
Yeah.
here to do your nub. Here for your nub X-ray.
Do you,
Oh.
do you ever have to
Separate
get
your
that.
fingers. Wait.
the
Oh.
X-rays of the limb? Like if they come in with their limb, do you take X-rays of the limb?
Absolutely.
Like the detached one?
It's just
Yeah.
on a.
Like if they come with like a
I told you
ice
about the
bag.
finger I did, huh? The severed finger.
Yeah.
I told you that story. The 3-view severed finger on a 2-year-old.
Ugh.
And you take
Well,
it
what
off
do you do, like,
ice
roll it?
to do the
It was
image.
weird.
So did you take a picture of like their?
So they ordered a 3-view finger on a 2-year-old little boy. I go into the room and say, I'm here to do your finger X-ray. The nurse is over there attending to the patient. I'm here for the finger X-ray. She goes, there it is, right there. And literally, there's a finger on a tray next to the patient. I'm like, you want that finger? I'm like, yeah, we want to see if we can reattach it.
No, the other ones.
So I'm like, this is new.
Yeah.
So I got my gloves on. It was on ice, by the way, too. It was on ice. So I had to take it out of the bag from the ice, put that little bitty 2-year-old finger on that giant digital cassette
Little Vienna sausage.
with a little sausage. It was a very cold, clammy sausage.
Oh.
It was really weird feeling. It was very gelatinous and very
Ew.
cold, and it was surreal.
And then there's
I'll,
the baby
I'll never
fingernail
forget how
on
it
the
felt. It
end.
was really weird. So I had my vest on. I'm all right. Okay, here's my PA finger. Okay, little finger, I'm gonna put you in a PA position. I didn't really say that. But
Uh-huh.
I'm sitting here. What was awkward
picture him
was I'm
saying
sitting
that.
here positioning this finger,
I'm gonna take
and the little boys,
Here.
the little
No.
boys sitting there staring, freak out. I'm like,
I'm
I
here to
promise
save
I'm
you.
taking great care.
I'm here to save you,
Those
finger.
eyes, you know those eyes.
He's just sitting there just
Yeah, those eyes.
like, oh. And I'm just like,
It just pierced through
feeling
you.
so awkward positioning this finger.
So-
PA, oblique, lateral.
I have a
These things
actual
easy?
genuine question.
Yeah.
At least it didn't
They
move.
didn't want the hand with the finger like a little gap, like, you know.
Wait, what now?
They didn't want the hand with the
They
finger
just
like.
wanted the finger by itself.
That's so wild.
So they didn't even order a hand
They
X-ray.
did not order a hand, just a finger. So,
It
I
could've
did
looked
my
like this, you know?
3-view severed finger, and they were able to reattach it. They were able to reattach it because it had been on ice. And that does work, by the way. If you ever have someone that severs something, put it on ice. It can save the parts.
What if it's dangling?
If it's dangling, try to still put it on ice.
Oh, here's show me.
So that was really weird. That was really weird. That was the one and only time I ever did a severed limb like that. That was strange.
You just did it in the
Well,
patient's,
I take that back. There was one more.
patient's room.
Uh-oh.
So yeah,
You just took pictures of the fingers in the patient's room.
yeah. I put a vest on the kid and the family as well, and they just sat there watching me position this cut off finger.
Were
That
you
was
allowed
just
to,
so
like,
weird.
Take it back to the department and show it there.
No, it was in the room.
I misread you.
the severed penis
When you said
sex
shoot it
remember?
there.
Oh
Oh,
yeah,
that's
you
right.
told
I
us
heard-
that one.
That one was
I heard
that was
you
still
it
attached
there.
by like a thread.
Chewing on it.
That was weird too.
Did they put that on ice too?
No,
No.
Is that attachable?
no.
Because he came on.
But I don't know. I don't know what.
He did what?
She did what she?
Oh,
He
he's
did
alive.
Came
what?
and said he made this by mistake,
That was
and then he
a
was.
PA
I don't think
lateral
he had the sense
soft
to
tissue
put
penis
dyes.
X-ray.
He cut
Please
it in the
look at the
bottle.
request.
That's what it said. It said soft tissue penis X-ray.
Remember he bought the razor from
was-
the thing,
Yeah.
Walmart.
Oh, you talking about that?
As weird as it sounds.
Yeah.
I'm like, hey, excuse me.
That was as weird as it sounds. Yeah.
Oh yeah, I remember that story.
PowerPoint froze.
Oh,
that
end of
was
the
like
day,
time.
yes.
Someone play the Hunger Games sound.
Something wrong with it.
Can we take a small break?
I can take a small break. I gotta see what time
What?
it was. Take about 10 minutes.